really delighted that you're joining us here this evening. For those of you who may not know me, my name is Annette Jones. I'm the President and Chief Executive Officer of Stevenson Memorial Hospital, and I'd like to just extend on behalf of the board a warm welcome and thank you for joining us this evening for our second speaker in a three-part series. The three-speaker series, we know that everyone can't make it out to every session. We're delighted if you can, but knowing that with scheduling, each of these sessions are being videotaped and they will be posted on our website. And after the third session in January, there will be a short survey monkey asking you to provide us some input, feedback, once you've heard or seen on the website each of the speakers, and we'd be delighted to have you do the survey. And essentially, it's just engaging your feedback about the key issues in the healthcare system. So on that, without any further ado, I'll introduce you to our speaker for tonight. We're just very excited. Deanne Salaswalo, she is our Chief Information Officer for 3 hospitals. I don't know how she finds the time. She's the Chief Information Officer for York Central, Southlake, and Stevenson. And we're delighted that she could be with us here tonight. And I'll hand it over to you, Deanne.
Thank you. Okay, so thank you very much for this invitation. And I will be speaking about eHealth. I know that perhaps it is in Ontario a tarnished word at the moment, but there is much work to do about eHealth, and I will present from a national perspective what has occurred and an update on that, the provincial and the local perspective about eHealth. And I'm looking forward to the discussion and the question period at the end. I will be speaking about Canada Health InfoWave, eHealth Ontario, the ICT Collaborative, just to give an introduction about what we have accomplished to date. Stevenson, great progress there, and as well some healthcare trends and key technology trends in healthcare we need to be mindful of. Canada Health InfoWave. We all know that it was created in about 2001 as an independent, not-for-profit organization, and it is accountable to the 14 federal, provincial, and territorial government. So they have a big agenda since 2001 to basically provide timely, appropriate, secure access to the right information when and where they enter into the healthcare system, they being us when we enter at any point in the province or everywhere. There used to be a date as to when this would be all done, but it's such a long journey that the funding is being given in increment to produce that work. So, and I'll explain that. So, Canada Health InfoWave so far has spent about $2.1 billion in federal funding for eHealth. And I will explain what they have accomplished to date. And the next slide talks about that the capital cost that it will be required to accomplish this big agenda is about $10 to 12 billion. However, the benefit that will be derived from that are about $6 billion to 7 billion, and I will explain that some of them have been accomplished to date in this area. So, how this is going to work? Sorry, I need to let you know when I need the next slide. So, it is recognized that we receive care in many places. So our records are everywhere. It could be here at Stevenson, at Southlake, at Sunnybrook. Some records are in the pharmacy system, your local pharmacy, a local lab, another long-term care maybe, or a clinic. So we really need to have access to one place to have all this information, so that at the end of the day, the picture will look like, the next slide here, one patient, one record. That's the goal. At the end of the day, that we will have one place where we're going to view the medication that you receive so that we can check for conflicts, drug interaction. We will see the lab result you've just had so we don't have to repeat them unnecessarily. So that's what occurs. You come to maybe here for Stevenson, you're transferred to Sunnybrook, they may repeat all the lab tests. That's what costs money, and the diagnostic tests. So then they will have the ability, Sunnybrook, to view the record that you've had here at Stevenson. And this has to be all done in a private and very secure way with rights as who has to look at the information, can look at the information, and having some audit trails related to that. So that's a big commitment from the province and the national perspective. So there's a lot of work from a setup that needs to occur there, and that's where all the costs are going for that. So this is the record. This is what eventually, I would say within 4 to 5 years, at least in Ontario, we will have that for Ontario. And how linked it will be from a national perspective, it will take a few more years to get the data if you're in Vancouver and you happen to have care there. Then it will take a few more years to link all the province together, but every province is working on the same standard, so it'll be easy to link all this information. So first we need to do some work at the local level. Us here at Stevenson, we need to get a lot more automation than what we have today, so we will be able to publish that information into that record. And it will be linked with all the other side. So that's the goal, one patient, one record. So far, Canada Health Infoway has done about 50% of the work that with the funding that they've received. So it's an ambitious target. It's a lot of work, and within they're going to receive another sets of funding. Every year they get the funding from the various provinces. So that's how they are able to operate, and there is a commitment to that. The next slide talks about the national perspective. What have we done? What has been done so far with the 2.1 billion? A lot. So I've got this right now here. So for example, number one here, the red, it's the registries. Registries is the ability to build a record for each patient with their name, address, record number, basic demographic information. So every province now has a registry. There's one here, like everybody's got one, so they all have their registry. And that's important because we will want to make sure that John Smith in BC is the same John Smith in here, so that when the records are called to pull all this information, it pulls all the right information about John Smith. So registries are being built right now for that purpose. If I look here in Ontario, we have, we see diagnostic imaging in green. Pretty well everybody actually does have a diagnostic imaging repository. So there's about, in Ontario, about 8 repositories. You're part of one of them here. All the images from the diagnostic imaging are sent to a repository called HDIRS, Hospital Diagnostic Information Repository System. So I think there's about 28 hospitals that sends all their data into this repository so that people can have access to all your diagnostic imaging in one place. That already exists, so one thing we've done. We're working on another project called the lab. The lab is this color here. So there will be one in Ontario called Ontario Lab Information System, OLIS. Some of you might have heard about that. It's being built right now. And South Lake is already publishing data into that repository. York Central will be next, and Salt Lake Stevenson will be next to be able to publish their lab result into that system, so that main system. So over time, we are sending data into these repositories so that we can view the composite of all your information into one patient, one record. And that's how it's going to work. So from a Canadian perspective, lots of work done, a lot more to do. From all the drug information system, we don't have much in Ontario yet. For that telehealth is big. Telehealth is actually one of Canada's largest video conference network in Canada for telework. So it means that, especially for remote location, patient doesn't have to travel to come and be cared for at Sunnybrook. They can go to a telemedicine site in North Bay, and a physician at Sunnybrook will be at the telehealth site, and they will connect. They will see each other like Skype, like we do, but it's a much more sophisticated program. You have the ability to view a little bit better if you have a cut, or if you're looking at a skin lesion or any other problem, you can do a little bit more diagnostic from that e-visit. So there is so much, they're apparently saying that they save about 47 million kilometers of patient traveling by using telehealth. So it's quite significant so it's, Canada is actually, from the world, is actually doing quite well from a telehealth, which is the yellow. And so you can see the yellow is pretty well all installed everywhere. So that's basically the activity summary from a Canadian perspective. Next slide. So spending about 2.1 billion and more, going to 10 billion to 12, if not more, we need to really have some signposts of success and some evidence that, yes, we are making a difference in the outcomes of patient and the result and so forth. So if you look at diagnostic imaging, there is a saving that has been accounted for, about 600 million. It increased the productivity for technologists by about 20 to 30%. So those have been documented. For the drug information benefit, the pharmacists are saying that there is less, that they have been able to prevent a lot of problem and drug interaction, which is an accounted saving of about 400 million. This is data from Canada Health Infoway, so they've done their research on that. And the last one is on the telehealth, which I just explained. So it's connecting right now about 1,175 communities together. So that's the extent of the network around telehealth, so it's quite big. And their saving is about 47 million kilometers to do that. Now, what will it take to get more presence about the telehealth, to use it more? In Ontario and other provinces, when a physician does a telehealth visit, they're being compensated for it. So it's a billable service. So it's the only way we need to move forward is by the ministry to change some of their policy. Because at the end of the day, it is work, it is clinical work for the physician to do these e-visit, e-telehealth visit, because it takes time in the day to do that. So that's why we got such a high adoption, because they were able to change some of their policy around fee-for-service for that. And the same would apply for like an email, corresponding with your physician via email. Right now, there's not a lot of take on it, because it takes time, and it is considered a clinical visit, but policies need to be changed to follow and do an adoption around that. So I'm going to speak a little bit about eHealth Ontario. You know a fair amount from the media already, but I think the page is turned now. Lesson learned, and we all, take some accountability for what occurred, unfortunately. There's some lesson learned and better process, better practice. So we are marching along with eHealth Ontario to be one of the provinces that also will implement some of those technology. This is the vision, basically, that we have for eHealth Ontario. They're playing a key role in harnessing the information technology and innovation. What are the program and service that they are working on right now? And one is diabetes management. big project that involves some of the LIN, but this LIN is not yet involved in that project. I think the LIN that is involved is one in the Champlain area and the other one in the London area. Those are the two LIN that are involved in this project for diabetes management. The other one is e-prescribing. There's a couple other LIN. This LIN is not in this project yet. Drug viewer profile. All the hospitals in Ontario are actually on the drug viewer profile, which means that when you come to eMERGE and you are 65 and older, all your medication are already on a repository. So you come to eMERGE and the physician can have access to all the medication you already are taking from various hospitals or different pharmacy, you had prescriptions, so they can see all the medication you're taking, and from there, in eMERGE, they quite often do medication reconciliation and make changes right there about some of the medication you should be taking or some you should not be taking, because now there's a drug interaction, and that's the place they usually find that out. Unfortunately, it's too late, but at least we have a drug profile viewer. So already in place, Stevenson is using it in their eMERGE. Oops, next slide, sorry. Drug profile viewer. So then resource matching and e-referral. This is an application where it's going to become a provincial mandate that every hospital and CCAC put their resource, their referral online. And I'm quite pleased to report that today Stevenson went live. In our central end, they're the third hospital that went live, successfully live, and actually setting a trend here. The physicians are actually entering the data in the system. No one else is doing that. So they're setting quite a target for the rest of us who will follow Salt Lake and York Central in the next month or so. So resource matching, which means that once you have a referral to make to CCAC, you're going to do it online, it goes to CCAC, and then they will match home care for your visit or whatever you will need to be at home and be continuing for the care. And that should speed up the referral process and reduce the wait time for that, and hopefully reduce beds in the hospital by being able to place the patient earlier from the system. So congratulations to Stevenson for going live today, and very well. And thank you, Shannon Lowry, for your executive sponsorship to this project. Is well noted at Central Land. So thank you. Physician eHealth. So physician eHealth is where the physician will have in their office an electronic medical record. Some of you might have your physician that all their information is online. There are about 11 physicians in this area that have an electronic medical record already. So we need more. All the physicians should have an electronic medical record. They get funding from Ontario MD for this. And it's gradually, the numbers are increasing over time, but it will take time for that to occur. But 11 in this area that have an EMR. Ontario Lab Information System, you're not on that yet. You will probably be next, so that's why I don't have it in blue to differentiate from the other one. Diagnostic imaging, we're done here. You are connected to HDERS, which is the Diagnostic Imaging Repository for this area. There's 28 hospitals on that, so that project is done for here. Enterprise Master Patient Index, that's done. That's being linked to a big patient index from the province. So all the hospitals actually in Ontario being on the wait time are part of that, the MPI. So we're done here to be connected with that. And then connecting GTA. Connecting GTA is building an infrastructure where all the hospital and the pharmacy and the lab and clinics will be connected on one network, so we can send this data into one place. So we have to build that highway, that infrastructure, that technical piece. And we're just starting this project, and we put an application to be one of the early adopter. So we put an application for York Central, Salt Lake, and Stevenson to receive funding to be the early adopter for that project. So we're waiting to hear on this. So that's where we are for Ontario to the landscape there. Now let's talk about the Information and Communication Technology Collaborative, the ICT, with the 3 hospital. We've started that in 2005, and why we did that is because we were all having the same system. Our system is a McKesson provided technology, so that's the software we had in all the 3 hospitals. We had many other systems, Med 2020, I guess it was an abstracting system we had in common. We had some materials management system, and we had many systems in common. And in 2005, I've approached the CEO and I said, perhaps we should get together in one collaborative and try to merge into one IT group that will support all the 3 organizations. And we've been quite successful since, actually. It was all to improve the service to the user, establish a stable, flexible infrastructure. For example, we all have the same network. So it's Nortel or Avaya. So if there is a need to have resources here, we can send everyone from the 3 organizations here to fix it, because they all know the network. It's one network for all the 3 organizations. So a lot of skills can be pulled to solve the issues or do the implementation of system. And we have realized a lot of cost efficiency by getting together. And I will talk a little bit about this, about what we've achieved. But we needed to start with a strategic plan. In 2007, actually, we got together and tried to look for a strategic plan for the 3 organizations that for the next 4 years. You need to have a plan in order to be able to secure the funding. And so that has assisted us in, for example, in the clinical management. I'm not going to go over all of this, but in the clinical management, we will implement standardized electronic patient record for acute and ambulatory service, all the 3 sites. So we have the same lab system, we have the same pharmacy system, same diagnostic imaging system. So we are implementing one system for the 3 organizations. So you create a lot of saving, and also it's easier to manage and sustain at the end of the day. So, and I'm not going to go over all this, but that's one of actually my favorite slide. It's everything is there at once on one slide about our plan. But we're going to need to refresh it pretty soon, and I'm going to talk later on about what we will be including in our next reiteration of the plan. Next slide, please. So what have we achieved from the collaborative? A lot. From a purchasing saving, now we buy licenses, Microsoft licenses in bulk, because we have 3 organizations, so we got a much better price to purchase that. Our device, PCs, printer, laptop, much better price, because we're 3 organizations, larger volume, so we've been able to negotiate all of this. We also can share our staff from business and clinical application. We share our implementation strategy and our staff, so the implementations are done faster. We have one network for the 3 organizations, the same network, and the same on the telecommunication as well. We have, for example, of application that we are on the same platform, the Horizon patient folder, which is upcoming. So we're going to send, when South Lake implemented that Horizon patient folder, we sent the team from York Central, who already implemented it in 2000. We sent them to York Central, and they help with that implementation, and we'll do the same for Stevenson. The electronic documentation system, we send the team from South Lake to York Central. Save a lot of money. You don't need to use the vendor to come and help with the implementation. It's much faster, and you save a significant amount of money that you can reinvest in moving the agenda faster. And what else do we have in common? Wait time, resource matching, ER tracking board. I think we're similar ER, similar tracking board and Emerge. I'm sure you've seen that. A risk management tool we've developed for the 3 sites. We're using that, and the encryption device that we use for protecting the information. So we've been able to do that with the 3 sites. So basically, from the collaborative, that's what we've been able to accomplish. Let's talk about Stevenston more at the local level and where we are with our strategy. That slide is coming from the OHA. Every 4 times a year, they do a survey and they ask questions about where are you in your journey towards the electronic medical record, electronic health record or electronic medical record. Every hospital answers the survey, and then we are compared to where we are and we stand. So I'm just going to go over the stage. The stage 0, you don't have anything really, so we're past that. Stage 1, you have to have lab, radiology, pharmacy, all installed. We're there. Stage 2, control medical vocabulary. You may have a document imaging system. So those are the systems to be able to get to stage 2 that you have to implement. Stage 3, you have to have an electronic documentation, error checking, PACS available, outside radiology. Stage 4, CPOE, which is a physician computerized provider order entry. That's when the physician will no longer write on the chart the orders for the medication and all of that. They will do it all online. So York Central and Salt Lake are preparing towards that journey, and Stevenston will get there once they move on the stage here. And then closed loop medication is where you're at stage 5, which means you go to the bedside, you will barcode the patient identification band, the medication, so right medication, right time, right patient all the time. So that whole closed loop medication is in that stage. And stage 7, stage 6 is physician documentation. They do all the documentation online. And stage 7, then you connect everything together. So stage 7 is really in the domain of eHealth Ontario. This is what they're preparing us. So we need to get there in order to align here. So you probably heard in the media that North York, for example, has achieved, they're at stage 6 in their journey. So as Toronto East General, it's because they've done all of this and they're doing physician documentation right now. So that's where they are. So where are we at Stevenston? We're not quick. We're about 1.03, so to be precise here. That's where we are. So we have a little bit of a long way to move up the ladder to get there. York Central is about 3.1, and Salt Lake just reached 4.1 recently with their CPOE in the cancer center. So that's the. So I'm going to go over the next slide. I'm going to explain the sheet that you have. It's a bit complex, but I'm going to go over that. So here, Stevenston, this is stage 1. This is your score, 1.0390. So that's why we're responding to all the questions got us to that number. So the average score for all acute care hospitals in Ontario is 2.3. Okay? So the average score for your peer group, small hospital, it's 1.6. So we need to catch up to be at least at par with our peer hospital, 1.6. And we're getting there with the plan that you have put forward. So then it gives out the score, but this is the 1.6 here we need to be. If we want to be close to our peer hospital, small hospital, we should be close to 1.6. And the average score of hospital in the central LEN is 3.2. Okay? So here's the I like this part here because stage 1, for example, that's everybody has done an ADT, it's green. We have an ADT, we have a DI PACS, we have a lab system, we have a pharmacy, radiology. And the percent here of acute hospital that have live DC gives you the percent. Everybody's pretty well there. We need a clinical data repository. We're in the red here, we don't have one. We have a drug information system. So it just shows where we need to do the work to get to the stage. So that just illustrates that. Okay, next slide. And again here, those are just graphic for, this one is where Stevenson is at compared to, you see, there's a lot of people that are in that stage 3, a lot of hospitals, I should say. Here it talks about, this is comparing same like hospital of small from Stevenson. We're here, so St. Joseph Eliot, LK, that would be Eliot Lake, that's right. A little bit higher here, so it just represents where you are here. IT salary compared to the IT operating, we're here. And operating budget spent on IT, 1.5% of your operating budget is spent on IT. Okay. You have a great plan, though, to get to the next stage. A lot of work has been done. You've completed, I'm going to try to read it from here so I don't turn my head here. You've completed the Horizon Physician Portal. You can access that, some of that. You, for those physicians that work at South Lake and come to Stevenson can access the Physician Portal, but more work to do to have every physician accessing that information from their office. You have implemented Up-to-Date, which is an application where the physician can get information about care. So it's a web-based application. You've got an electronic whiteboard in your Emerge. So you've got, I'm not going to go over all of this, but you're progressing really well. This is the dollar that it costs for each of the application. I have to give credit to Danny Mainville and his team at Stevenson and Miles actually to have put that all together and so forth. So the next slide. So this is 2010, a little bit of 11. Now you've got you've got another series of projects for 2011, 12 in your plan and so forth. So it goes, it's a very good plan. Next slide. I think is that it? Yeah. So you've got your other projects so to continue. So needs a plan in order to know where we're going. It's a long journey, but you will progress towards that stage 3 or 4 of the EMR. Okay. Okay, so while we have this plan to 2014, we really need to start thinking about, okay, so what's next? What's upcoming? What are the trends that we need to pay attention in our next iteration of eHealth plan? So there are some healthcare trends, for example, patient safety, that is big. So we need to have tools that will help us to reduce any risk and mitigate any risk. Personal Health Information Protection Act means that we have to put application that always pass the test of being secure and to keep the information confidential. Accountability and performance-based, we have a lot of demand to produce data for the LIN and the ministry, for example, wait time, ALC. So we need to have tools that will help us to do that, like a repository where you can put all this information in and you can query it and get the report much faster than we do today. The same goes for business intelligence. We need to start asking the hard question. Question like, are we making an improvement in the health of, or the outcome of a treatment? Is this medication given for this particular diagnosis is making a difference? Is the patient leaving or getting better earlier? So we need to be able to query the data. We have a lot of data, but we have no ability to query it and get some answer and analyze and do some research around that. So we're going to need to look at systems that will help us to do that. Patient and family-driven care. I think we all, and it goes along with the chronic disease management, having access to your health record at home. What do you do today? You come to the hospital, then you go to health record, and you ask for your record, and you probably pay a significant amount of dollar to get it, because we need to photocopy it and that. And then some of you probably go home and try to enter this into a little database so that at least you can follow your lab result on your cholesterol level, so you see if you're improving or not, or you're trying to sift through all this paper. Makes no sense. So we need to have the ability to provide you with access to your information at your home and work with that. And you can see if your cholesterol level is going up and down, and you can make changes in your diet. Those visuals are very important in making changes. So these are the trend, and the key technology trend to support that will be making sure that we have everything barcoded. The identification band has to have a barcode. The medication, little envelope of the medication has to have a barcode, so that you can barcode everything so that it all match. So this barcoding, or RFID, what it's called. So we need to implement those technology. Connecting medical device to the electronic health record. Some of you may have a CPAP machine at home, and there is probably a chip in it, and you probably may want to have this connected to your health record so you can see your progress. Or connecting in intensive care all the cardiac monitoring system into the electronic health record, so you don't have to re-enter all this information. It's automatically linked. Patient-centric portal, I just spoke about that. Unified communication. Boy, how many devices do we have? We have a phone, we have a BlackBerry, we have an iPad, and a PC at home, and that whole convergence of one device, there's a lot of work that needs to be done there. Unified communication and use of mobile technology in healthcare. The same, everybody wants to bring their own device, and they want to view their information on that device when they come to the site. So we need to be able to support that. Telemedicine, we are connected actually on the telemedicine side. And making sure that we also continue working with eHealth Ontario on all these projects that I named earlier. Remote monitoring of health, sending a patient home, and the patient is able to get on the scale, and you weigh the patient, and that information is sent to the hospital, to someone to view or give an alerts with their blood sugar and all of that, being able to monitor the patient from home, connecting the blood pressure cuff and sending that information, so preventing an emerge visit, so you can connect with the patient and help them with making changes. So those e-visit that can occur by remote monitoring. And the whole greening of the technology, making sure our data center doesn't consume a lot of power, unnecessary power, so that we virtualize all our servers so it costs less money for the organization. So then at the end, I had thought of playing a video. It's only 3 minutes, but it's a hospital in Norway that is a digital hospital. It's produced by HP.
This is how many think of hospitals, a place for emergencies. But a hospital is far more than that. We are at Aarhus University Hospital, a normal and busy 600-bed hospital outside Oslo, Norway, but also one of the first digital hospitals in the world. HP's Digital Hospital is an architectural concept which allows you to network everything with everything using IP technology. It is a framework which allows you to plug and play with different components. An environment which is instant on, totally connected, fully integrated, and which allows data exchange across any organizational boundary. Aarhus is also the European site for HP's Health Center of Excellence. At the Health Center of Excellence, we demonstrate what if with components, technologies and applications to showcase different ways communication technology can be applied to your set of challenges and goals. What if you could do like modern stores do and enlist and engage your patients to make your outpatient flow more efficient? What if your patient entertainment system also showed training videos or provided questionnaires and links to websites and thereby empowered your chronic patient to improve her clinical situation? What if your phone system only called staff if they were present, or your printers only printed papers that you need? At the Health Center of Excellence, we show you elements that may be parts of your unique solution. We show you how Digital Hospital lets you both choose a solution and change it when your needs change, without forcing you to repeat the original investment. So what if you take the trip to see the Health Center of Excellence at Aarhus and ask yourself, what if?
So that concludes the presentation for now. And so I'm looking forward to any question. Thank you. Yes, right now, what takes so long, and I'm part of that, if I start at the national level, I'm on committees where we're discussing the standard. What is the standard for lab nomenclature, the lab test? What are we going to call that? What is the standard for the network? So right now there's so much work in defining the standard. Then once you have the standard defined, then you can build it. Otherwise, everybody will be building something that will be different and they won't connect. So a lot of times and money right now is spent on defining how it's going to look like, the privacy piece, the standard. That's what takes so long to do. It is a very good question, because open source means much less cost to purchase a laboratory information system. And I know that some hospital in the US, actually one in Ottawa has a lot of open source application on their iPad that they're using. And we can go that route. So to me, if you take Ottawa, in order to have all their physician application open source on their iPad, they have 40 staff just to do that and manage it and maintain it. You can go that route and do it yourself with your staff and take the system from an open source. Or you have less staff in your IT and you go with already built application. So I think with the vendor, the cost is high. It's higher probably than open source, but you need to ensure that you have the infrastructure to manage your open source application, to sustain it and maintain it and upgrading it, because you're on your own. You're on your own. So you just go and grab that application and you work with that. So that's my view on that, but we are challenged to go and look at those sites that have those open source systems. The Veteran Affairs, I believe, in the US, they are big open source client actually, but they sure have a great infrastructure to manage it and support it. I think that we need to start looking at our catchment area. It will make sense. I'm just going to babble a little bit. So we need to have our system locally to be able to, we need to work locally and then meet halfway with eHealth. I'm not going to wait, we're not going to wait for eHealth Ontario to have it all. That's why there's no reason why we cannot take our patient that has diabetes, that have their device, connect them to the phone, and this information is now sent to Stevenson or South Lake to view it, and then if there is a result that is above the normal, then it gets red and it flashes. But that's the whole area of chronic disease management in our circle of care here that we can view. So we are starting to work out the logistics of what does it mean to care for the patient at home and send that information to this dashboard visual in the hospital or the clinic or whatever it is so that they can see. So we need to staff someone 7/24 there to view this, call the patients. I noticed that your blood test here is higher. Are you doing okay? Do you need to make change? Can I help you? Can I send somebody from CCAC to go and visit you? That whole link can occur because the technology, you're absolutely right, all there right now. But there is a whole logistic and infrastructure process that needs to be in place to make it work, because you cannot send the patient at home with all these devices and then nobody's looking at it. So we just need to, but it is there, I know that. So I hope I answer your question. But we can do it ourselves here. Don't have to wait. It's a good question. So the province of Alberta has been far much more advanced, and the out east, you see this area here a lot more, but the size of it is the size of York region for some of them. So they've been able to go a little bit faster than Eddie. So from a readiness perspective, they have a lot accomplished, and the Alberta and BC, and Ontario, definitely we're lagging. We're not on the top. But we will get there. At some point, we will get there like everybody else. But to answer your question, then from an international perspective, country like Norway, Sweden, Finland, all their physicians in their office have an electronic medical record, and it's all linked together. So those countries are fairly advanced. From that perspective. England, Paul, you were right, you were there, and they're pulling out their strategy, their funding. You know, they probably will channel the dollar rather than doing it from a national perspective, more at the local level, and get the sector to be more on electronic media than waiting for the national perspective. So that's probably their rationale. That is very recent that they have pulled out their entire funding for that. So anybody else could comment on the status of other places, you're welcome. Yeah.
So thank you,
Deanne,
for